a little bit about the influence of body temperature on neurologic outcome. And thank you for having me here to talk about this too. Acknowledgements, this was funded, it was my dissertation research, which was funded by NIH and the Moore Foundation. I went to school here at UC Davis. And as far as disclosures, I didn't have a disclosure slide, but I don't really have any disclosures. I'm a volunteer faculty at UCSF. I have been working here at UC Davis until Sunday, and then I'll be working at UCSF. And I'm on a couple committees for the Neurocritical Care Society and AANN, as well as being president of the Agnes Marshall Walker Foundation. So there we go. All right, I think a lot of this information maybe looks a little familiar to all of you. We've discussed this a little bit through the day today. Traumatic brain injury is a big problem. A lot of us are interested in it, and we're all interested in helping our patients to do the best they can after any neurologic illness or injury. And so, as has been discussed, we're thinking about a lot of the things that we can do at the bedside. We're not the engineers that can adjust the routes of travel, or the engineers that make the helmets that can protect to prevent primary injury, but we can minimize secondary injury by making sure that we're doing the best that we can to take care of these patients in a timely fashion. The limitation is that we don't have a lot of robust evidence to support our practices. So as Karen mentioned, and I think Linda mentioned earlier too, prevention of secondary injury includes looking at patients' body temperature, and we have an understanding that fever is bad in the injured or ill brain. As Karen mentioned, healthy brain tissue can tolerate temperature that is elevated quite high. However, in the brain injured patient, they don't tolerate it as well. So the trick is that we've all had this really big interest in looking at temperature management, and initially we were very interested in hypothermia as an intervention, but regardless of the findings that I'll go over a little bit of others' research and mine, there's not a clear consensus of what normal temperature is. And so Karen mentioned normal temperature we know is 37. And so if you look at different institutions, different research studies, there are different definitions of that range, because it's like when you're pregnant, how many people deliver at exactly 40 weeks? How many patients are really sitting at 37 degrees? So there's a little bit of a spread that we think about, but that spread's different depending on where you work or what you read. So there's a lot of opportunity for us to figure that out, and challenge for us to interpret what information there is that's available. So what literature is there about temperature and patients with brain injury and different types of brain injury? Now, I mentioned TBI is my personal favorite, but there are lots of types of brain injuries that we take care of. So looking at the literature, there is some pretty strong literature for hypoxic ischemic encephalopathy, and that is such a mouthful. I always find myself pausing to take a breath before I say that mouthful there. So HIE, for little babies who are injured, there's been good literature, and there's a Cochrane review along with some other papers that have really clarified how hypothermia is beneficial in this patient population. As with all of the patients that we look at for temperature management, in addition to any kind of interventions, time duration, and intensity of treatment are things that we consider. And it's been pretty well defined for this patient population, as the information on your slides, on the slide notes, that it shows that there's improved outcome. There have even been studies that look at outcome not just at 18 months after birth, after injury, which was 18 months of age, but even out to 6 or 7 years of age, that those kids have lower death rates overall, no increase in the significance of or the rates of severe disability, or differences in IQ scores among kids. So, of course, just like in any of these scenarios, we want to make sure that we are helping people. We're helping people to survive in a quality way, not just survive. right? So here's some good information about hypothermia as a treatment for hypoxic ischemic encephalopathy in babies. Cardiac arrest is an interesting topic in which hypothermia has been looked at. So people have looked at inducing hypothermia in patients who are unconscious after cardiac arrest. And while there are lower death rates with therapeutic hypothermia, as noted with the Cochrane review, and AHA endorses hypothermia for both shockable and non-shockable rhythms, and there are different levels of evidence for those. There has been a recent paper that has been criticized, but still brings up the question of hypothermia versus normothermia, if you define 36 as normothermia. And really, I think a lot of discussion has come about to say, well, is it really fever avoidance and really targeted temperature management for our patients, or is it hypothermia? And so I think that there is some healthy discussion happening as a result of what people have looked at so far. Stroke, there is a lot of question about clarifying where do we set our goals for temperature management, and depending on what type of stroke, there's stronger evidence in some areas than others. Fever is known across populations and diagnoses to worsen outcome, and that's clear in the literature. But whether you induce hypothermia or you avoid fever, there are different recommendations depending on what body of literature you look at and in which type of stroke population. Temperature and traumatic brain injury is what I looked at with my dissertation. And so first I looked at the literature, like I briefly did with these other diagnostic groups, but looked to see what does temperature, what do we know from the literature? And we know that hypothermia on admission, or spontaneous hypothermia, patients that come in cold with a traumatic brain injury have poor outcomes. And there is some question that came out of the University of Washington. Hillary Thompson, their group looked at rate of rewarming of patients that potentially could be detrimental. And so we know from a lot of the hypothermia studies, induced hypothermia from TBI, that rewarming too fast can negate the benefits of hypothermia, specifically with ICP, along with some other aspects of patient outcome. And so the question is, if someone comes in hypothermic, we know that they may have a poor outcome, but how do we manage those patients? And ATLS doesn't have recommendations, advanced trauma life support, regarding a rate of rewarming for patients who come in cool. So that was something that I was very curious about in the research that we did here. As far as induced hypothermia, like I mentioned, there's been a lot of research. Everyone who's talked about TBI management has talked about hypothermia, because we've all been very interested in that. And unfortunately, there's a lot of variability in how the studies about hypothermia have been designed, and how the control groups, you have an intervention group and you have a control group, and that's supposed to be essentially everything's managed the same except for the one intervention. For example, in this case, it would be temperature management, so that everything else is standard of care plus this additional item, and seeing if that additional intervention improves neurologic outcome. Some of the studies for hypothermia, the control groups weren't truly standard care, because if someone came in cool, they might have been aggressively rewarmed, or the definition of hypothermia or normothermia or standard care may have been different depending on the studies. And so it's hard to take away a really confident message from the different studies. Now, we know from animal model studies and cell culture models and single center studies that hypothermia has been promising, but the multi-center studies looking at neurologic outcome have either been stopped for futility or haven't really had good analysis as far as the outcomes for the patients. Now, mild hypothermia it has been found to be beneficial to control elevated intracranial pressure, but in terms of neurologic outcome, one study there wasn't really any difference in the neurologic outcome at 6 months after injury. Longer cooling periods can help control ICP better, and we know that clinically we see as our patients get rewarmed and they have elevated ICP, as they rewarm, you know that when you have them cooler, the ICP is under control. So rewarming rates are of concern and aren't clear across different studies. There has been some post hoc analysis of some data. Guy Clifton looked at one of his looked at his data with the hypothermia studies and saw that perhaps people who had a mass lesion, like a subdural hematoma, if they were cooled before they went to the OR, that they might benefit from hypothermia in improvement of outcome. And so that actually has been something that a few groups have looked at, and that might hold some promise. But I don't think that we can conclusively say that hypothermia is a first step intervention that we can do in TBI based on the strength of the literature that's available. And you can see the Cochrane review gives that same endorsement, but that was from 2009. Unfortunately, the literature between then and now hasn't conclusively increased the confidence in being able to say that hypothermia is a good first-line measure. Although we know it helps with ICP, it hasn't helped with long-term outcomes. Something that has become more of interest has been the concept of keeping people normothermic. The group in Pittsburgh with Eva Puccio looked at ICP burden, intracranial pressure burden. So they looked at people who were normothermic versus people who had usual care. And the patients who were kept normothermic had less ICP burden, meaning their ICP was elevated less significantly and for a shorter duration. And while they didn't look at neurologic outcome in those patients, that surrogate measure of ICP burden was better in the normothermia group. There have been some other studies that have looked at normothermia versus standard care, and standard care again is a little muddied as far as do those patients get medications to treat fever, or what is their definition of normothermia, and that varies among the studies as well. But it's pretty clear in a couple of the studies at the very least that there's a lower probability of death. The idea of living and dying as an outcome measure has been a pretty standard way of interpreting our interventions. But there are a lot of limitations to that. As nurses at the bedside, or as nurse practitioners, or as anyone who's counseling family or loved ones of someone who's been injured, and all you can say, oh, they're more likely to live or die, you really want a little more granular detail about how well that person might survive. And that's another thing I've been interested in that's a little bit of an aside. But I think that that's something we need to think about in looking at what we do for our patients. The last item on this slide, fever, is really, maybe it's a no duh. We can all get this by Gestalt, but it's nice to know that there's data that supports our Gestalt, right? So earlier fever for our patients with TBI resulted in lower quality survival. So someone might have a fever at day 1 or a fever at day 3, and the person who had a fever at day 3 was better off than the person who had a fever at day 1. There might be pathophysiologic reasons why, because we know you would be able to say pretty confidently that an early fever within that first day of injury maybe is related to significant hypothalamic injury or a significant injury that had a higher inflammatory response versus someone who had less of an injury but had an infection that mounted a couple days down the road. But regardless, timing of fever is an important thing to identify, as well as severity of fever. The group in Japan has a great database looking at traumatic brain injury patients, and they looked at temperature in terms of stratified temperature levels and then number of days of having what level of fever, and found that if someone had a more severe injury, or if they had a more severe exposure to fever, that they did worse. Their outcome was worse. Further, fever days were equated with longer ICU stays, but weren't necessarily equated with outcome in one group study. So lots of good information, but not a lot to walk away with to be able to say, all right, based on all this information, this is what I'm going to do with my patient at the bedside. And that's really what spurred my interest in looking at this, was because we were looking at how we managed our patients with severe traumatic brain injury to see if we were really walking the talk. And we noticed that a lot of patients had fevers pretty early in the course after their injury. And so it got me thinking about, why did those patients have fevers? Or was it something that we were doing? Like, was it that we saw someone came in hypothermic and we were so ready to intervene that we put bear huggers on and overshot our goal of normothermia and made them febrile? Or was it their inflammatory response? And what type of aspect of temperature was important in relation to neurologic outcome? So those are the questions I had going into looking at this research. I looked at data from UC Davis from a single center, a level 1 trauma center here, and looked at moderate and severe traumatic brain injured patients that were 16 years and older during a 4-year time period. Part of the inclusion was that someone had to come to UC Davis within 12 hours of injury, because I was very interested in looking at temperature as soon as I could get it after injury through 4 days after injury, which is 96 hours. And so I wanted to make sure I had at least 3 hours of temperature measurement, and that it was at least, like I said, within 12 hours after injury. Another piece that was very important, like I mentioned, is neurologic outcome assessment. And so we have a great registry in our department where the neurologic outcomes are assessed, and so including that 6-month neurologic outcome. So speaking of neurologic outcome, I touched on this earlier, but most studies look at, like I said, survival or mortality, or favorable versus unfavorable outcome. And so it's all, sorry, I'm not speaking in the microphone, but I shout, I think, so we're good, right? My kids will say that I am really good at projecting, so I might not even need this. So back to this. Glasgow Outcome Scale score. Great score. It's a way, just like the GCS, to have a common language about these patients, about their neurologic outcome. Initially developed in '75, it's a 5-point scale right there in the middle. Basic, straightforward, gives you like the really big picture idea. Someone dead, vegetative, severely, moderately disabled, or good recovery. Now, good recovery, there's a lot of variability in what that looks like, right? I don't know, what was it, like 13 years ago now, that the GOSE was developed, I think. And that has a nice script and has a little bit more detail, 8 points on the scale instead of 5 points. Not a neurocognitive battery of tests for sure, right? It's not going to give us super details, but it's going to give us a little bit more information. And for those statisticians out there, you can use linear regression with it. I bet there aren't a lot of people that care about that, but it was important in the design of my study. So I wanted to look at the GOSE because I felt like as a clinician, it could give me a little bit more to talk about in terms of detail. It's not going to help me say whether, Johnny's going to be an astronaut or a garbage collector, but it's going to be able to give me a little bit more understanding, or at least a better sense of a little bit more detail than survival or not. Because sometimes survival is not the best choice, and I don't mean to be grim about that, but I think that that's another really good conversation we have to have with our colleagues and just in general. So, what things did I choose to look at with temperature in these patients? Well, rate of temperature change. Like I mentioned, Hillary Thompson and the group in UW were interested in rate of change. They did a secondary analysis and thought that maybe rate of change or correction of temperature abnormalities might be a concern that we need to think about. And we know from some of the hypothermia studies that rapid rewarming negated the benefits of hypothermia, and there were issues with intracranial hypertension. So I was interested in looking at rate of change of temperature to see if there really was an importance in the rate of that temperature change, or if you think about it linearly, the slope of that line of temperature over time. Then looking to see what was their minimum temperature overall or in different time intervals, as well as maximum temperature. I didn't want to go in with set strata of temperature levels. As clinicians, we need those sort of thresholds of if the blood pressure is less than 90, do X, Y, or Z. We have thresholds like the threshold traditionally has been temperature greater than or equal to 38.5, do this. But I didn't want to set an arbitrary threshold because my thinking was maybe we chose the wrong arbitrary threshold. And what is that magic number? Is there a magic threshold that if we adjust that bar is there a difference? And so that instead of having our set point of intervention being 38.5, maybe it's 37.2 or 36.8. I don't know, I'm pulling that out of a hat. But the point being that maybe there's some database decisions that we can make for those intervention thresholds. In the same vein, I also wanted to look at not just fever, but hypothermia or cold temperature to see if there was any importance in staying above a certain level, or if there was any positive or negative effect in that regard too. And like I was talking about, that I didn't want to just set an arbitrary threshold, I also wanted to look at the dose of temperature. So when I talk about dose of temperature, I don't want to look, as a lot of people have done in the literature, at a set point of someone being above, let's say 38.5, to use that same example, during a time interval, but really to see, that you can imagine that the difference, that there might be a qualitative difference between someone spending an hour at 39 degrees versus 3 hours at 38, right? So I wanted to be able to look at dose of temperature, both elevated and lower temperature, to see if dose of temperature was important as well. So that is a funky name called aberrant temperature dose. And I made that one up, and I bet it sounds a little goofy, but it is to reflect this area under the curve and area over the curve. And those are statistical terms. The AUC doesn't necessarily correlate with what I'm talking about. So I'm going to show you a cartoon so you can see. So here we go, aberrant temperature dose. So you can see, like, the horizon is 37, right? That's what we have defined as normal. And so for my dissertation, just like with any other research, you really have to have clear definitions for both your data gathering and your analysis, right? So the team of experts that I gathered for my dissertation committee told me I needed to choose a threshold, and rather than choosing 36 to 37, which was my first stab at a range, they suggested that if I was saying that 37 is normal, it should be a bandwidth around there. So 36.5 to 37.5 was the range that I identified as being normal. Anything above 37.5 would be considered fever for the study. Anything less than 36.5 would be considered hypothermia. Now that may not be true overall for reality for clinical scenarios, but that's what we chose for the design of this. So first, to get around this concept of dose, so yellow, whoop, there it is. So the yellow area is the area under the curve that I'm talking about. The temperature dose above our threshold, which is this dotted line up here, area under the curve. So anything above this line, above, it's supposed to be 37.5, so sorry about that. So anything above 37.5, we would measure this area, these areas. So see, we're not measuring the whole area above 37, it's just above that horizon of 37.5, our upper threshold of normal, to see what that area is, that dose. Same thing with area over the curve. It's just that the curve is down here, so we're measuring above the curve up to our line of threshold, which was 36.5. So there it is conceptually. This was looking at existing data. Good side of it is that I have lots of information. Bad side is I don't have a lot of information. So there were, I think, thank you NSICU nurses. I had 25,000 individual free text comments on these patients. Isn't that a good time? Yeah, so I coded a lot of them, and that was fun. But the temperature measures, the source of temperature was not consistent. I had to take what I had. That's the downside of existing data. So Karen mentioned earlier that the Neurocritical Care Society guidelines for multimodality monitoring were recommending brain temperature, which is something fantastic, right? Go to the source. Charmaine Childs has done a lot of work looking at brain temperature and temperature and neurologic outcome with TBI. However, brain temperature measurement happens hours and hours and hours after injury. The average time from admission to the ICU, so it's not time from injury, it's from admission to the ICU, is 11 to 14 or more hours. That's average. So the windows go up to 32 hours after injury. So that's more than a day after injury. And what I was really interested in doing was looking at temperature, the temperature measure that we have available that we can do something about from when they come into the recess room. So I used body temperature, I used what measures were available, and I used identified correction for measures that we know aren't as accurate. Now, that's a limitation of the study, to correct for an axillary temp. I'm right there with whoever wants to criticize it. I know there are limitations. But, I felt like we had to go with what information we have clinically in real practice. Now, the prospective study that can be done, if you would like to fund it for me, would be that I would identify a core measure. Maybe it would be a bladder temp, because that's what we used with the NABISH studies. But a core measure that's consistent across patients, and that would be the most rigorous design. Now, in a perfect world, we get a brain temp monitor as soon as they hit the recess room, but that's never going to happen. So we looked at, there was no restriction on the severity of injury, the AIS scores or the injury severity scores. So you might imagine that more severely multi-trauma, polytrauma injuries might have more inflammatory response. And actually, there were no good correlations with that, so that was a good bit of information. But that is another thing that could dirty the sample. So these are all very important things. Absolutely, the variability of temperature, things that we did. This is existing data. So what does it mean if patients were given a cooling blanket, or if they were given a bear hugger? I wanted to look at what are the outcomes, regardless of what happened. What are the outcomes? What does it matter what these people's temperatures were? And then the next step would be to be able to control for all of those things, of course, too, although you're never going to find someone randomizing people to a fever group, right? So what happened? Thank you, Bonnie. All right. Okay, so the results. Were you all chomping at the bit? So here's a little picture of what the sample looked like. So whittling it down from a whole bunch of, gosh, I don't remember the initial number of patients. I actually have it somewhere, but it escaped me now because I've been so mesmerized by our discussion. No. So this is 340 patients that I looked at, and this is what they represent here. So the average age is very representative. If you look at the CDC data regarding TBI in the US, it's pretty consistent. Maybe it's a little bit older, but the range is appropriate, as is gender. About 70% nationwide patients are male versus female. So that's also very fitting. Ethnicity and race, that's representative of the area perhaps, although clearly it's skewed toward a white population as far as the sample. It wasn't biased toward that in any selection. That's just what popped up in the eligible subjects. Mechanism of injury and race, I note here are just the top 3 that occurred. We've had all different kinds of mechanisms of injury present here. Granted, we certainly have more blunt injuries here compared to, say, Highland Hospital, where there's more penetrating, but these are the top 3. And then transport, direct versus transfer. Now, direct versus transfer in this sample is probably higher than our actual direct versus transferred from an outside facility, because of that window of time that I really wanted to restrict this to, and that people needed to come to UC Davis within 12 hours after injury so I could have their temperature data. In an ideal world, now that we're all EMR-ified, we could share data, right? And there would be no silos of information, and there would be, like, I don't know, kitty cats jumping over fences and rainbows and fairy tales. But we're not there yet. I know, okay, I'll stop. I need my afternoon coffee. All right, so it might be scarier then. Looking at how these patients did as a whole, I have for you here the dichotomized survival versus death at the top. So 70% of the patients in the sample survived. And then the favorable versus unfavorable outcome down here at the bottom, 58%. So not too great unfavorable. Yes, unfavorable. Moderate or severe injuries, this sample that met this group, there's a room for improvement, perhaps for us, or these patients are badly injured but not enough to be killed. So what's the bottom line? We're not there yet. But a little bit of information to wet your whistle. Rate of change. I was so convinced I was going to go to American College of Surgery and say, you need to have guidelines on rewarming rates for TBIs, for ATLS. No, it didn't matter. It didn't matter at all. Now, maybe it was my design, but I don't get to go to ACS and say anything, Bonnie. Yeah. So, but I think it's good to think about, right? The data just didn't have any significance in rate of change. And in the first 24 hours, which is officially the resuscitation phase, because you do your tertiary exam by 24 hours, or not even in 18 hours, which is what I thought by looking at some of the data, that maybe there were steeper slopes within that window, that people maybe reached a peak within that time. And so I looked at the slope, that temperature over time in that window, and none of it mattered. Going up, going down, neither way, no luck. But fine, it's good to know, right? We don't want to go in with a bias. We go into research with a hypothesis, with an idea of what we think, and then we go to prove ourselves wrong, or otherwise. Well, I proved myself wrong in that one. So there's true science at work. The other issues, and one of the people in my group, Ava Puccio, she's from Pittsburgh, she was on my committee, she said, well, we should look at first temperature measure, see if that mattered. Didn't matter, not at all. Corrected, uncorrected, didn't matter. Okay, so what about fever or hypothermia? Minimum or maximum temperature? Minimum, maximum temperature in and of itself, not so much, but if someone had fever within the first 48 hours after injury, or were hypothermic in any of the 96 hours after injury, they had a higher likelihood of death. And remember, those measures were 36.5 and below, or 37.5 and above. It's a small window. So that's interesting, I think. A little more detailed information here. Looking at 86% of patients with a temperature less than 36.5, or about the same of greater than 37, in the first 24 hours, that resuscitation time, died. So that's kind of big. There are lots of reasons why people might have temperatures outside of that range, right? Especially the low ones. Like maybe they went to the OR for a big long time and they got colder than cold in there. Fever during any time period. So I had to break these up into time intervals, so they were 24-hour time segments. And if you have looked at research design or statistics, it's not good to stratify continuous variables like time or temperature, but we sort of have to be able to get digestible bits in some ways in certain scenarios. And admittedly, I don't like it, but I did it. Just like I set those 36.5 and 37.5 thresholds, those 24-hour windows. So fever during any of the time periods, any of those 4 days after injury, resulted more in unfavorable outcome or death. And hypothermia, particularly early, was statistically significant in association with worse outcome, as was fever with that GOSE. So I looked at this data in a couple different ways. Now, the literature out there looks at outcomes with research, like I showed you earlier, and those dichotomized outcomes, favorable or unfavorable, death or survival. And it's on or off, right? So in order to compare apples to apples, to compare this data to the existing data, I did that on or off, live or die, favorable or unfavorable. But I still wanted to look at things with that spread. And like I mentioned, with that geeky excitement about the 8-point scale that I could do linear regression, that's what I also did, other than doing it the old-fashioned way of logistic regression. So I looked at it with the full scale, and hypothermia and fever were also significantly associated with worse outcomes, lower points on the GOSE, compared to those who did not have it. In addition, the dose information, remember that yellow and purple? Dose of hypothermia, actually along with dose of fever with another analysis I'll show you, was associated with worse outcome. Now, this is kind of contrary to what the literature has said about hypothermia in some regards. And in fact, a statistician that I really respect, Nancy Temkin at University of Washington, first looked at my data and said, oh no, I don't think that, I think it's those correlations are really positive, and it made me really worried. And then she looked at it in more detail and said, no, you're right. So So here are some of those correlations, looking at the dose of temperature. So this is Spearman rank correlations, and it's a rank rather than a looking at data in more regression analysis. You're looking at them in a non-parametric way if you've been using statistics recently. So just to orient you to this, we have the correlations here, and then we have the significance level. And we all know significance level, if it's 0.05 is usually the threshold. Well, we don't care about those as much when we're talking about correlations because we're also interested in looking at the correlations. And so you might get super excited about these 0.00, 0.001, 0.001. Those sound nifty, but look at that. That kind of stinks. This one. So these correlations aren't as exciting, but when you look at the linear regression, it's significant, along with all of these other measures that I mentioned to you before. So the dose of temperature above 37 degrees, or the dose below, and it was even more significant with the hypothermia doses, along with these other variables in these different phases. So remember, I was talking about these 24-hour chunks, so the resuscitation phase, looking at the variability of temperature. This is another thing I didn't mention earlier. When you think about variability of temperature, is that important? So when you're looking at measures, you can look statistically at the standard deviation or standard error. And so you might have numbers here versus someone with a higher standard deviation might have variable measures versus a smaller standard deviation would be closer to the mean, okay? So the more variability in temperature was associated with worse outcome. And this is with that 8-point scale again. Now you'll notice that the number of patients in each group over each day go down. The resuscitation phase, the first 24 hours, 340 patients in there. 24 to 48 hours, I lost 10 people. They died. 48 to 72, 306. 72 to 96, 271. Yeah, so there's attrition, and so the power of the analysis goes down too if you're thinking about statistics. It was another limitation of existing data, but another fact of looking at this patient population. Patients will die because of the injury itself. Patients will recover better. Moderate injuries might get an epidural evacuated and then seem super great and then get to go home. So that's a good reason why they fall out of the study. Or they might get expatriated back to their facility of insurance. I won't mention those. But just the same, the numbers go down. Now, it was suggested that I might take out those patients that whittle away, the people that die or the people that get transferred out or people that get discharged. But you're missing out on those patients from the real world that we are seeing and taking care of. And unlike a lot of the research, there's a lot of literature out there. If you look at TBI literature, patients who are GCS of 3 or non-reactive pupils or that combination are excluded because they have a high mortality. But we're taking care of those people still, aren't we? And so I'd like to know what this looks like for them. So I included them. So there, it was my study. So temperature matters in all of these different time frames and these different aspects, aside from the rate of rewarming, they matter. So I looked at temperature by itself on a lot of those things, but I also wanted to look at it in terms of known variables, known things that influence outcome. So Linda mentioned hypoxia and hypotension. We know that doubles mortality. We know that there are a few things that are important in predicting neurologic outcome. Is anyone familiar with the impact model? It's from the CRASH data. There are about 8,500 patients in this database from US and international trials where all the data was put together and analyzed, and outcome prediction models were developed based on that. And so based on the number of variables, there are increasingly complex statistical models where you can enter data. You can go to, if you've got Wi-Fi and you're still listening and not tuned out on me, you can look up the impact model online and you can put in variables for a patient. There's a huge disclaimer at the bottom that says this is not in any way, recommended for individual patient prediction, blah, 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 like those new car ads. But it's a way that you can look at these different variables and have a likelihood of outcome prediction. Again, it's that dichotomized live-die, favorable, unfavorable, but still, that these variables predict outcome. So that was a long story to introduce this topic, wasn't it? I used those variables, those things that we know well predict neurologic outcome in this patient population, as a way to control for things that we know influence outcome, like age, Glasgow Coma Scale Motor Score, glucose, hematocrit, head CT scan findings. And I looked at those by themselves with our data to validate the model. And then I looked at those with the temperature data. And by the way, like I said, that model with those predictive items looked at live-die or favorable, unfavorable. So I did it like that, and then I did that fun GOSC analysis. The model performed well with our data, so that meant good. I can use that and move forward with the temperature data. The temperature data improved the accuracy of the model. So what does that tell us? That if you put enough things in the bag that it makes it more predictive? Yes, that could be the case. If you put enough things in there, you can predict things pretty well. But it decreases a couple of measures that you can do statistically to see if it's really the most ideal model. So I looked at that, and it didn't negatively influence. So ultimately, the bottom line was that temperature measures, the variables about temperature, improve the accuracy of outcome prediction, both with live-die, favorable, unfavorable outcome measures, as well as looking at the full GOSC. Temperature is important. So what does this mean? Does it mean that you go back to your institution and you manage your patients 36.5 to 37.5? You shouldn't make changes based on a single center's single data dissertation. Even though I'd love to say, yeah, do it. No, but it begs the question for more research. It begs the question to not conclude that hypothermia is the end-all be-all. Body temperature matters. The variability matters. And so hypothermia and fever were associated with worse outcome. Variability was associated with worse outcomes. So that begs my question, maybe controlled normothermia is what might really help. So the next step, aside from looking at more broad existing data, which is what I hope to do next, is to really look prospectively at patients and see if controlled normothermia is helpful. And so I think there's more research that's necessary, and maybe I get to do it, or someone should. Invite me to play if you're going to. I'd like to thank the people that were involved in this. There are a bazillion people that helped me, particularly the nurses in NSICU, which is where I was born as a nurse. I started as a new grad here. And the Department of Neurosurgery, as well as all the people listed below. They were either on my dissertation committee, on my NRSA mentoring group, or on my qualitative exam. So, we all want our kids to stand on the shoulders of giants, and I got to stand on a lot of giants to be able to achieve this. So thanks to everyone who did it with me and supported me, and thanks to all of you for listening.